Welcome everybody to our TIF Talk this afternoon or evening, depending on where you're located. I'm Andrea Millers with Endogastric Solutions. And today we have our special guest, Dr. Chris Cottrell. Welcome, Dr. Cottrell, and thank you for being here tonight.
Thank you very much. It's a pleasure.
Thank you. So just a little background on Dr. Cottrell. He is a general surgeon at Advanced Surgical of North Texas, located in McKinney, Texas. Dr. Cottrell received his undergraduate and medical degrees from Texas Tech University. His medical interests include reflux and minimally invasive laparoscopic and robotic surgery. When he isn't working, Dr. Cottrell enjoys spending time with his family, cooking, and his medical podcast, and anything with a microchip. So I think you call yourself the GERD nerd, right, Dr. Cottrell?
Yeah, it's on the wall, so I can't take it, but nurses back in the day made a license plate that says that, so yeah.
That is fantastic. Well, we're so happy to have you here tonight. We've got some exciting stuff we're going to discuss, but before we do so, everybody watching, as you guys know, this is a live event, and you are welcome to ask Dr. Cottrell any question that you'd like, obviously relating to GERD and the TIF procedure. You just need to comment on the comment section either below or to the side of that, and we'll do everything we can to answer your questions. In addition to that, we have a very exciting giveaway today. We're going to give away our TIF tumbler to people. All we ask of you today is to comment where you're tuning in from. And so once you comment where you're tuning in from, at the end of the night, we'll pick a couple of winners to win the tumbler. And one of our colleagues, Karen Morrison, will be reaching out to you and letting you know if you won or not. So please do comment where you're tuning in from, and ask us any questions that you may have tonight for Dr. Cottrell. So thank you again. And let's go ahead and start. Oh, well, before I do that, Dr. Cottrell, maybe tell us a little bit more about you and your practice. I know I mentioned that you're in North Texas, in McKinney, but maybe give us a little more insight on what you and your practice and what you do up there.
Yeah, our practice, for me anyway, I really have always had an interest in reflux and reflux surgery. So that's been my primary interest. Of course, we have a broad base of general surgery. As the practice has grown and as we've become more experienced in the robotic platform, at this point, we're doing the vast majority of our cases robotically. We actually pulled numbers, and I guess I did some 400 and something robotic cases last year, which is kind of crazy. Didn't feel like that last year, last year being so strange and all, but we're doing acute care robotic surgery, which is a big, exciting thing that we're doing now. So emergency surgeries that traditionally were done open, we can do that minimally invasive now, which decreases the length of stay by a lot. So a patient that might have normally stayed 7 to 10 days recovering from a large incision might just spend sometimes overnight, sometimes maybe 2 or 3 days. So the acute care portion of our practice has grown quite a bit in terms of the robotic surgery. You mentioned in the introduction the laparoscopic surgery. At this point, I barely do any laparoscopic surgery. It's something I was certainly trained in and did a ton of, but we've converted it all mostly to robotic just because of the increased flexibility and the amount that we can do more complex surgery. So I think that's the biggest thing that's most exciting about what we're doing.
Wonderful. Thank you for sharing that. You survived the Texas. You survived the snowpocalypse. Now
we got very, very lucky. It turns out that if you live on the same grid as a fire department, a retirement community, and a hospital, that you're the last ones to lose power. So we never actually lost power. So our house fared just fine, thankfully.
Well, I'm glad for that. So let's go ahead and get into it. We're here to talk about GERD today and the TIF procedure, obviously. So can you tell us a little bit about GERD and give us a scientific explanation of what is GERD and what could patients potentially feel if they were suffering from, chronic acid reflux?
Sure. So you kind of said something there. You can end up confusing the terms a little bit. GERD and acid reflux and heartburn they're all related, but GERD specifically is gastroesophageal reflux. So that means stuff coming from the stomach up into the esophagus. And, it's something that doesn't have to be acid. Now, we tend to feel it when it's acid. And so we feel that as heartburn. So that's kind of a couple different things. So GERD, gastroesophageal reflux, is just the reflux of material up into the esophagus. Acid reflux implies that it's acidic, that's doing that. And then heartburn is what you're feeling. So those are things that it's easy to kind of confuse those because they are so related. And, it is semantics to a certain degree, but at the same time, kind of important, because depending on what you're doing to treat these things, you may not have the symptoms, but actually still have GERD, for example. So it's kind of important to know the difference. But in terms of reflux and what it is, basically the definition GERD just means, reflux material from the stomach into the esophagus. It's a very basic definition, but why does that happen? Why doesn't everyone have heartburn all the time? A lot of people have heartburn, but not everyone. And why doesn't everyone? And patients ask us all the time. And so in the rooms, my patient rooms, we have these large whiteboards that, I then start drawing on and stuff like that. And actually, we can try this. I've got a thing here, and we'll see if we can't draw this here. Okay. And I can kind of go through what reflux is. Let's see if this works.
Awesome. Let's see.
Hopefully we can get this pulled up. Okay. But I don't know. Are we good there?
I believe so. Let's go ahead and start, and
let's see how it goes.
See if there's
any problems,
any issues. We got thumbs up.
Okay, good. All right, so we should be looking hopefully at a white thing now. But basically, sorry. Okay, so change color. Okay, yeah, that should be all right. So hopefully this is sort of centered right. So how I draw this is basically, this is the stomach and esophagus, okay? So this is the stomach and this is the esophagus. And then basically what you have here is, that's the diaphragm, right? So this is the muscle that controls breathing. And it separates the chest from the abdomen. Now, no matter what size you are, or whether you weigh 100 pounds or 400 pounds, there's always going to be negative pressure in the chest. That's how we breathe. The diaphragm contracts, the volume expands, the pressure drops, and air rushes in. Then in the abdomen, relative to the chest, we're going to have positive pressure. Okay, so what happens is things naturally, the gradient goes from the stomach or the abdomen up into the chest. And this gradient is usually greater than gravity. That's why you can have reflux even though you're standing up. Okay, so, trying to erase, and it's just making more marks. All right, so then reflux, if we naturally are pushing from the abdomen up into the chest, then why doesn't everything go up into the esophagus all the time? And the answer is, there's this area of esophagus that is just below the diaphragm, okay? It's the intra-abdominal esophagus, okay? And the esophagus is kind of a very flimsy tube that just has sort of two layers, whereas the stomach is this big, robust, sort of three-layered muscular structure. And so this positive pressure acts on the esophagus and kind of squishes it. That's a technical term, squish. But basically it collapses it and makes it difficult for anything to go back up into the chest, okay? So the amount of intra-abdominal esophagus is very important to the reflux barrier. Now, there's also something called the lower esophageal sphincter, which is basically in the same area, and it's similar and related. There's not a specific ring of muscle or sphincter, but this part of the esophagus acts as this barrier. So this positive pressure pushes on the esophagus, collapsing it, okay? That increases this lower esophageal sphincter pressure, which then means that nothing comes up. So that's what normal situations look like. When we have a disruption of this barrier, that's when reflux occurs, okay? So when this is too relaxed, or is sucked up into the chest so that everything gets sucked up in there, that's when reflux is allowed to occur. Okay.
Yep.
So when this is disrupted, that's when you get reflux. So that's the anatomical thing. There are also some hormonal things that can do this. And there's a lot of complex relationships with that, various drugs, foods, time of day, as a matter of fact. But and those are a little bit more complex, and that can help relax that sphincter area as well. But for me, it's most about the intra-abdominal esophagus, so that when we're trying to repair and fix things, we're trying to restore this relationship, the intra-abdominal esophagus being below the diaphragm.
Yeah. Yeah. That's really great. So maybe keep that up and let's discuss what happens with medical therapy. What's actually happening when someone's taking a PPI or any type of medication to help their reflux?
Sure. So again, when we talk about semantics, basically when we're taking a medication for reflux, you're taking it for acid reflux. So traditionally, back in the 1950s, before we had good medications, all you could do is either drink milk or take an antacid, right? So all you would do there is literally neutralize the acid. So you would take Tums or drink the milk, and that would help neutralize the acid. Just in chemistry, we're acid-base type equations, but basically you have something acidic, you add something basic, and it neutralizes it. And so that stops the acid reflux and then stops the heartburn. But it doesn't do anything with this mechanism whatsoever. So what you end up happening is you still have reflux, it just doesn't burn anymore. So it controls the symptom of heartburn quite well, but it doesn't really do anything for the anatomic relationships that cause the reflux. So then as we learned about what the GI system works, how the proton and acid producing cells in the stomach work, we initially sort of found out that there's some stimulation to those. And so we tried to block the stimulation, and that's what the H2 blockers do. And there's three parts of that system, but H2 is one of them, of the histamine 2 blockers. And so those blockers sort of decrease the amount of acid that the stimulation of the acid. And those helped quite a bit. And those are the more traditional medications, cimetidine and others, ranitidine and whatnot. But basically, it decreases the acid production. It doesn't eliminate it, but it decreased it by quite a bit. And it really went a long way towards controlling that stuff. And then we came up with the proton pump inhibitors, and that actually just inhibits the proton pump completely. Thereby, there's basically no acid produced in the stomach. And so again, all those things, one way or another, decrease the amount of acid or neutralize the acid. That controls heartburn, and the symptoms doesn't really do a whole lot for reflux. And that's why those semantic labels are somewhat important, because you still have reflux. It's just, it doesn't burn. One that just has heartburn and that's it, that can control things enough that you can, live your life and not be sort of hindered by your reflux.
Yeah, good point. We do have a question that just popped up from Peggy. She's asking, I have GERD for about 10 years. I take 2 omeprazole. I'm assuming she's writing 40 milligrams a day, also famotidine, 20 milligrams. So it's just a comment, actually. So Peggy, I don't know where you're from, but I don't know if you know, we do have a giveaway today. So if you want to type or comment where you're coming from, you might win a tumbler today. But with that said, Dr. Cottrell, maybe we can kind of talk a little bit more about what are the different options for treating GERD today.
Yeah, so again, we kind of covered the symptomatic relief of heartburn, which is one manifestation of GERD. A lot of patients end up either kind of breaking through that in some way, shape, or form. So they take those medications, and the patient that commented, actually, she's already on 2 different medications. I'd be curious whether she's controlled on those 2 medications, and then furthermore, what made her add the second medication. And so you end up with people that can't, or either on the medications are still having symptoms, And then other symptoms aren't as amenable to just treating the heartburn, right? So if you have other symptoms of choking or symptoms where the reflux material comes up and you cough in the middle of the night, for example, people always talk about they literally just wake up and they're coughing and the stuff's in the back of their throat and they're having to spit it out and it just sits there and burns, even if they've been taking their omeprazole or other proton pump inhibitors. And so that particular symptom isn't super amenable to just medications because the stuff still comes up. When you do that, you run the risk of causing, chronic aspiration type problems where you get hoarseness in your voice, for example, or fatigue in your voice. Some people talk about throat pain. And those are all things that, are sometimes thought of as secondary symptoms of reflux, but can be more debilitating and potentially more dangerous when you talk about aspiration than just having heartburn. So those are the patients that typically end up seeking other modalities than just medications. Yeah. And so talking about who would require surgery or who would want surgery, it's that type of patient. The other type of patient would be someone who doesn't want to take the medications anymore. We see more and more where patients have either seen something on TV they didn't care for, or just particularly don't care to be on medications if they don't think they need to be. So strangely enough, and I would not have predicted this several years ago, we see a lot of people that are more naturopathic or holistic in their approach to things, wanting surgery, which is not typical, but at the same time, they would rather have sort of a restoration of a more natural reflux barrier rather than taking a medication for potentially the rest of their life. So,
Sure.
Yeah, kind of interesting.
Yeah. So interesting. Another viewer, Corleen, said, no question, but she's having the TIF procedure on March 4th with Dr. Willie Melvin in Smyrna, Tennessee. She says she's looking forward to getting rid of the GERD, but dealing with it for the last 2 years. And then Peggy, who we asked the question earlier, said, yeah, the meds are not working. And she's saying it sounds like to me, she said, I don't eat spicy food or try not to. So she's trying to already alleviate, all of those triggers.
Yeah. And that's something that other people, there's some great resources online where, and there's even whole Instagram pages that are dedicated to this of people that work on dietary modifications for the reflux. And that can be very helpful. And particularly if you're someone that enjoys spicy food or Italian food with a lot of tomatoes, acidic foods, lemonade, and stuff like that. These are things that you would definitely want to avoid unless you had a better control of your reflux, either with medication or potentially with surgery as well. So diet modification can be something. The ones I covered are acidic foods. That seems somewhat obvious, but there are other stimulants of acid as well, which is things like coffee, smoking, not a good idea. Peppermints can increase the amount of acid in your stomach, as well as caffeine and chocolate and things like that. So, there's a lot of things out there pretty easily searchable online, but in terms of diet modification, that can be a good early step, especially for someone that has maybe some reflux occasionally, and they want to avoid being on medications.
Yeah. So let's talk about, you talked about medication therapy, but there's other types of procedures. Maybe we can kind of go into,
Sure.
And then there's some questions popping up. Jordan, don't worry, I'll get to your question. But there are some questions about, what's the difference between a Nissan versus a TIF?
Sure.
Maybe if you can explain that would be helpful.
So the Nissan fundoplication is it's a surgery that's been around for quite some time. It's named after Dr. Nissan, who of course created it. I tend to mention this just because I'm a history nerd in addition to a GERD nerd, but he's actually the surgeon that operated on Albert Einstein and tried to fix his aneurysm, unfortunately unsuccessfully. But he's kind of an interesting guy in and of himself. But basically, he created this procedure where you take part of the stomach, and actually I can try and draw this. That might be more appropriate.
Yeah.
Let's see, I think I can just get a new thing here going.
Perfect.
But basically, when we draw the stomach, okay, so this is kind of the same pictures from before, esophagus and stomach. This portion of the stomach is called the fundus, okay?
Yep.
And basically this part, you surgically pull around to this part so that you end up with a wrap all the way around the stomach, or around the esophagus, sorry. And so what that does is it tightens up the area of the intra-abdominal esophagus. And anytime the stomach's contracting, it actually kind of squeezes onto the esophagus. And it does a pretty good job of controlling reflux. That's a Nissan fundoplication.
Okay.
Fundoplication just means that you're in some way altering the fundus, that portion that we circled earlier. And if we kind of, yeah, there we undo. Whereas a TIF procedure stands for transoral incisionless. So the other surgery, the Nissan, you have to make incisions, whereas the TIF procedure is done on the inside. So we can actually take the device, which kind of goes down the esophagus, and this is sort of representing the staple part of, not the staple, the fastener portion of things. But basically, we can internally wrap the stomach around itself. I'm not doing a very good job of drawing it, but basically, we make the valve right here at this GE junction inside the stomach over a dilator. So it's a lot less invasive. And as it turns out, the side effect profile is much better in terms of post-operative management. So while anytime we operate in this area, there's a little bit of swelling, and so for a short period of time, swallowing is a little bit altered, but that resolves very quickly with the TIF procedure, whereas with the Nissen procedure, that can be extremely prolonged. That's one of the biggest difference. With the TIF procedure, we generally get people back to normal diets within 4 to 6 weeks, whereas a Nissen fundoplication, in the best case scenario, it's about 6 weeks. But I've had patients myself and seen other patients where it's 6 months to a year before they even get close. And some of those patients will tell you that, yeah, I can eat, but it's slow and it's tedious and it's a challenge. So that's a problem. The other problem that you kind of wind up with is when you have that tight wrap of the stomach around the esophagus, if you think about it, anytime that you would need to vomit, if you were sick, the stomach contracting to force the vomit just contracts and makes that even tighter. So you get patients that can't vomit. And that sounds like, oh, that's great, I can't vomit. No, if you need to vomit and then you can't vomit, it's actually pretty distressing because it's described to me, I've never had it happen, but it's described as this sort of, you feel like you need to vomit and you just sit there and just kind of do this retching motion like you're vomiting, kind of painful, and then nothing happens.
Yeah.
And so it just kind of stays there until it goes another direction. And so that's pretty distressing as well. And then likewise, on a lesser scale, it can be hard to burp for some of these patients too. And again, that doesn't sound like the worst thing in the world, but I think we've all, drank a soda a little too fast and had a little belch that made you feel better. And imagine that never happening. And those patients will describe themselves as getting bloated or this traditional gas bloat situation that can be very uncomfortable. So for me, the minimally invasiveness is very attractive, but more importantly, the side effect profile is what really makes it attractive. And so the patients just do so much better and get back to normal eating habits and normal life so much faster. And as we've seen with the studies that have been done so far, it's something that seems to be at least as durable as what a Nissen used to be. And honestly, it's looking like even better. So yeah, it's a pretty attractive procedure. And that's why when we discuss this with my patients, it's not real hard for the patients to choose TIF. I can't think of a patient that's chosen Nissen in the last 5 or 6 years. Yeah. When you go over it like this. Yeah.
Yeah. Perfect. Thank you. Well, we got quite a few questions that have popped up, so we're going to try to get through these. Jordan's asking, can you discuss what to expect post-op? So sure. After the TIF procedure.
So every surgeon's going to be a little bit different. Everyone has their own sort of habits. My patients, I still am a little bit more traditional. As I get more gray hairs, I tend to watch patients just overnight. The overall complication rate from the TIF procedure is exceedingly small. And that being said, again, I am very, very careful. So we do make sure that everyone looks good the next morning and there's not any evidence of, esophageal injury or anything like that, which has been just not really an issue, but I'm still just very careful. So they stay overnight and then they go home on a liquid diet. And I explain it very simply, anything that could go through a straw. You don't have to drink it through a straw, but it has to be able to go through a straw. And that doesn't mean you can stretch out a noodle and, anything that you could easily stick a straw into and get it up, it'd be fine. And so in general, pudding, yogurt, and Jell-O are about the thickest things you should have when you go home. And I find that just makes it easier. I used to give patients a big long list of foods that were okay. And unfortunately, that always generates loophole seekers. And so pretty much anything that goes through a straw. My only caution would be carbonated beverages. Carbonated beverages can put a little bit more air into the stomach and make you bloated. So you might want to be careful with that. But other than that, anything that could go through a straw. And then after that, and we're seeing these patients every week to 2 weeks between me and my PA. And then it's a matter of moving on to what I call soft and slippery, or anything that you could eat without teeth, and if you couldn't make any spit. I like to keep it simple. So anything that will just kind of slide on down, and kids mac and cheese is a really good example of that. So I shouldn't say brands, but the stuff you can buy in the blue package with the powder, that goes really, really well usually. Anything that's kind of thick is really not a good idea just yet. And that, the first stage only lasts about a week or two, and the second one's a week or two. And then we move on to soft foods that are just moist. And I think of that as kind of most Mexican food, for example. As long as it's got some sauce to it, you're probably going to be okay. Just avoiding things like beef and bread. And then lastly, on to regular food. And like I said, that depending on the patient, 4 to 6 weeks on to regular food. In terms of what else it looks like, it means no heavy lifting more than 20 pounds for 6 full weeks. Okay. Because when we're doing this internal wrap, we want the stomach to kind of scar to itself just a little bit. And if you put a lot of pressure by trying to lift something or doing anything that's like lifting, where you're kind of straining against your core, that could disrupt things. So we don't want to do that for a full 6 weeks. And that'll be hard because you'll feel great and you'll feel like you can do that stuff. So you got to limit it. But other than that, most people get back to work within a couple of days to a week, normal activity as well. And a little bit of pain the night of surgery and into the next morning. And that pain with the TIF procedure by itself is usually gone by postoperative day number 2.
Wonderful. Great.
Hopefully that answers your question.
More so, you actually answered 2 questions. Someone just asked, when can they get back to vigorous exercise after TIF? Because, I think some doctors say, you can walk, you can, do light exercise, but it's a lot of these people that want to lift or do yoga or do something, vigorous. They're trying to see when they can get back to normal.
It depends on what vigorous means, right? Yeah. If you're talking about that you're a long distance runner, honestly, you can do that as soon as you feel. It's really just a matter of anything that's a weightlifting or weightlifting equivalent. And you got to be careful because, like cycling, for example, you can ride a bike, you can get on a stationary bike, but you can't do anything strenuous. So that means you can't get out of the saddle. That means, you really don't want to be doing any strenuous hill climbs. But if you're just kind of riding through the neighborhood with your kids or friends or something, that's probably okay. But then you couldn't lift the bike, that kind of thing.
That's good. That's good direction. Yeah. That's I'm sure. We've got a question from Freddie's asking, my father-in-law has been an on-the-spot PPI user, usually after wine or spicy foods. Would he be a good candidate for the TIF procedure?
On the spot, does that mean as needed?
Yeah, probably. That sounds like.
So it depends on how often they're doing that, right? And how much it disrupts their lives. Typically, it really just depends on how bad it hurts him and how often it happens. I would tell patients that if you're having to do that like once a month, I don't know that surgery's for you, right? I mean, that might be something that's probably okay, because if everyone eats enough pizza and drinks enough beer, you're going to have some reflux occasionally, right? But if that's something that you're doing 2 or 3 or 4 times a week and it's causing you to lose sleep, and you're having to take these medications long term, that's something to consider.
Yeah, thank you. We've got a quick question here. My mother got a lynx and had really bad dysphagia, and so I don't know if everybody watching knows what dysphagia means, but it just means trouble swallowing, right? And then they're asking, is dysphagia a problem with the TIF procedure?
So the incidence of long-term dysphagia with the TIF procedure is nearly zero. Basically, it just doesn't exist. Because the way the TIF is constructed, it's actually done over the device itself, which acts as a dilator, okay? So it's pretty much impossible to make it too tight. As we've kind of talked about, when you finish, swelling starts to occur as healing happens. So yes, there is some short-term dysphagia, but in terms of once everything recovers, that's really just not an issue whatsoever. So yeah, we're not seeing that like we did with the Nissan fund application. And then I don't do links, so I can't really speak to that. I wouldn't want to go too far into depth of that, but I have heard some people have had problems with that, yes.
Yeah, perfect. Thank you. Last question, I think here, why do you feel that TIF is the best option? You kind of mentioned that already, but maybe you can just let viewers know why TIF is a good option.
So I think it is a good option. I think for many patients, it is the best option. But the way I approach this with patients is we talk about their disease, and once we kind of work them up and we talk about things like their esophageal motility, how much acid they're being exposed to, how often they're taking medications, then we kind of go through what those options are going to be. I do talk about links, but again, since I don't do that, I can send them to someone who does. But in addition, we talk about the original Nissan fund application. We talk about just repairing the hiatal hernia, just repairing and bringing the esophagus below the diaphragm. And depending on the patient, we kind of make recommendations based on what their disease is going through. So it'd be really hard for me to say just blanket statement that the TIF is the best procedure for everyone, because, well, frankly, it isn't. There is not any one treatment for anything, really. But for many patients, particularly patients that are otherwise pretty healthy and just want to get off their medications, or the medications aren't doing it anymore, and their esophagus works normally and they don't have other reasons they couldn't have a TIF, for example, it's a really nice option. Number one, not the same side effects that we already talked about. Number two, it is minimally invasive, right? So even if we have to repair a hiatal hernia and then do the TIF, then we're talking about small incisions or no incisions, and something that we don't talk about a whole lot because, frankly, we don't have to do it very much. But let's say that 10 years down the road, maybe things have loosened up a little bit, or maybe someone's gained some weight and they're having some reflux again. It's a procedure that can be repeated. Again, we don't have to do that very often, but it's fairly easily repeatable, as opposed to any of the other surgeries. Anytime that you've operated near the esophagus, a redo surgery is and can be treacherous. There's pretty high-priced real estate in that area. Between posteriorly, there's the aorta. Just to the side is the vena cava. These are large vessels going to and from your body, basically, the main ones. The heart's not all that far away, and the liver's usually stuck to everything. So getting back in there and redoing a surgery is difficult. Whereas when we're going from the inside, everything's still open, and it's real simple to go back maybe in 10 or 12 years if needed. Now, we have not seen an overwhelming need to do so, but in the few patients that it's come up, it's a pretty simple thing to do. So there's a lot of advantages.
Yeah, we actually got another question that actually
Sure.
Two questions. Marissa is asking or mentioning, I failed 80% of my swallows on a manometry. Would I still qualify for a TIF? She's been on PPIs for 15 years.
So it's kind of interesting. It's good that you've had a manometry, because that can be super important, and it kind of guides our therapy. We got to be careful, because if the esophagus isn't contracting properly, we do run an increased risk of having difficulty swallowing. And so that being said, because the TIF procedure does not have long-term dysphagia problems, typically we don't make it worse, right? So you can still have the TIF procedure, depending on the workup, but I haven't looked at your data, but if everything else is being as noted, frankly, a TIF procedure would still be an excellent option. It's just, I would be counseling you that you might have a little longer period before you got back to regular food. That's usually the discussion that we have. Since your esophagus doesn't contract as well, it might just take a little longer. That's all.
Yeah, perfect. Thank you. So a reminder, if you're just jumping on to our show tonight, we are doing a giveaway of our TIF tumbler here. So if you comment where you are, thank you for, by the way, for everyone for asking questions, and we'll get to the next question. But if you are on and you're tuning in, please just comment and let us know where you're tuning in from. That would be great. So we have another question, Dr. Cottrell, from Lynn. She's asking or saying, I have high blood pressure. Am I a candidate for the TIF procedure?
As long as the blood pressure is managed appropriately and there's not other risk factors, that doesn't bother me at all.
Fantastic.
Yep.
Okay. Next question. Does insurance cover the procedure, and can procedures move forward at hospitals in Texas with COVID?
Oh, yeah, great question. I can only speak to Dallas. Well, I can speak globally. Back in March and April of last year, there was sort of a moratorium put on surgeries for it was about 6 weeks in terms of any kind of elective procedure. At that point, we were only allowed to do surgeries that were urgent and/or we thought the patient would deteriorate in the next 4 to 6 weeks. So that let us do cancer surgeries, acute gallbladder disease, appendixes, things like that. Unfortunately, any kind of anti-reflux procedure wasn't really seen as being in that category. That being said, nowadays, kind of as at first sort of the numbers didn't really come, and then we sort of got enough of the personal protective equipment and sort of figured out how to manage this, then we were allowed to do elective cases, but then we started testing patients before surgery. And then for a brief period of time here recently, when cases really got quite high in sort of December and January, at some hospitals, depending on need and availability of beds and things like that, there were some kind of rolling cancellations and or moratoriums placed on elective procedures. But for the most part, we're able to do elective procedures now here in Texas, and it just depends on the hospital, depends on the area, depends on how many COVID patients they have. But fortunately, as we're seeing vaccines roll out and the numbers starting to go down quite nicely, I kind of don't see that happening if it were to change drastically. So that hasn't been a problem. Now, with regard to insurance, we don't have an issue with that in any way, shape, or form. There's a recognized code for this procedure, when that basically means that Medicare covers it, and once Medicare covers it, pretty much insurance companies do the same. So the only thing is reflux disease. So we can't just talk once and schedule the procedure. There is a little bit of a workup that's required.
Wonderful. Thank you so much. Well, I think that's all the questions we have tonight, Dr. Cottrell. Is there any last bits of advice that you'd like to give our viewers that are watching tonight with anything? And then also where you're located and how people can find you. Have your address and your email and also your phone number on the screen. So if anyone wants to reach out to you, they're welcome to reach you that way. But yeah, any last thoughts?
Sure. Say that, if a patient is considering the surgery in any way, shape, or form, or if they're wondering, is my reflux bad enough to need the surgery and things like that, come in and talk, because and this happened last week where the surgery's not for everyone. I had a quite elderly gentleman. He was having reflux like once every 2 or 3 months, and we had a nice chat, and I kind of talked about a lot of this stuff, but at the same time, it just wasn't a good move for him. And so I'm not someone with just one hammer and everyone's a nail. We're going to talk about it, and you're going to make the decision that's good for you. There's a lot of people that just want to know how bad the reflux is and make sure that their esophagus is without, significant lesion, or there's not some other reason. And then we do the workup, we talk about the surgery, and they decide to wait. And that's great. ultimately, this is somewhat of an elective procedure. And so for a lot of patients anyway. And so it's a personal decision. So come in, talk to us, get educated as best you can, and make your own decision. That's what I would say. I think how to get a hold of me, there's a couple other pieces of information. There's a phone number, I believe, on screen, like you just said. That's probably the best way to make an appointment. We have a website that should be up there as well.
I don't see the website. What is your website?
advancedsurgicalntx.com. And there's a lot of stuff on there as well. And then I put together a podcast. It's Dr. Chris, the surgery guy. And there's we've done a couple episodes. I really want to do more. The time is difficult, but it is a lot of fun. And there's a number of things that I talk about on there, but reflux and robotic surgery is very prominent. So that's a good place to go. I also have an Instagram that has a lot of little good snippets of information pretty much daily. And that's Chris Cottrell, MD, at Chris Cottrell, MD. And you can also find that on Facebook, I believe, as well. So there's a couple other places to get information if you want, and other ways to get a hold of me.
Fantastic. Well, thank you so much again for joining us this evening. And for those of you that are not in the Dallas area, Dallas-Fort Worth area, we do have our resource website called gerdhelp.com. And obviously we have our Facebook page, but you can also go on our website and you can get into our physician finder, and you'll be able to put your zip code in or your state, and you'll be able to find a TIF trained physician in your area.
Sure.
As well, if you're not in that area. So,
and I'll just add, being in Dallas, we get patients from Oklahoma, Louisiana, New Mexico, and so we're happy to see patients from all over. The way we work things up, and now with televisits, we can see patients from all over as well.
That's a good point. That's a great point. Perfect. Well, thank you again, everybody, for joining us this evening. Again, our colleague Karen Morrison will be reaching out to you if you had commented where you're tuning in from. And Dr. Cottrell, thanks again for joining us. We really appreciate it. And we always love having you on here. So catch us next time on our next TIF Talk. I think we have one on Thursday. So we do have one on Thursday, and then again every Tuesday. So we'll catch you next time. Everybody stay safe, and thanks for joining us. Thank you very much. Have a good night.
Thanks again.